So the next drug was actually a drug that's been around for a while, but there's a new indication. So I talked about Rivaroxaban, which is one of the first of the novel oral anticoagulants. It was actually approved in 2011 to prevent blood clots after orthopedic surgery and also to prevent stroke in patients with atrial fibrillation. But only last year it was approved for another indication, which was for treating DVT and pulmonary embolus. And because of this new important indication, which has a lot of relevance for primary care, I decided to discuss the drug again, even though it's been out for several years. So for this new indication, we learned from the trials that I presented this morning that Rivaroxaban is non-inferior or as effective as enoxaparin plus warfarin for treating both DVT and pulmonary embolus. And that the bleeding complications, which again, as in the case of the first drug, would be the most important side effect, were actually also similar to existing therapy with warfarin and enoxaparin. So you basically had comparable degrees of efficacy and bleeding rates compared with existing therapy, but has, of course, the advantage that monitoring is not required, as is the case with warfarin. No other concerns came up in the trials. The most important adverse effect that the FDA was looking at was bleeding because it's an anticoagulant. So they looked at a variety of different bleeding outcomes. So for example, major life-threatening bleeding, intracranial bleeding, gastrointestinal bleeding, and then across an array of different sort of bleeding endpoints or adverse effects, the outcomes were similar to existing therapy. It wasn't preferred, but it was no different or no worse than existing therapy with enoxaparin and warfarin. So the most important difference for this new drug is that it does not require monitoring. So many patients are adverse to the idea of having to get their blood drawn, at least twice a month and often more frequent in the beginning or when it's being adjusted. And that can be a barrier to safe use of warfarin in patients who aren't able to do the monitoring that's required to use it safely. So the big advantage of the new drug, which again has been used for other indications before, is that no monitoring is required. And this is why many of our patients are asking us about this. And they want to know if it's as effective and equally safe. Might that be a choice for them because they don't have to do the blood draws. The other difference is cost, of course. All the drugs we talked about this morning are substantially more expensive than existing therapy. Rivaroxaban is more expensive than warfarin. But if you factor in the cost of the monitoring that's required, the costs start to be more comparable. From the patient perspective, because they don't pay for a lab test and just for the prescription, it may be more expensive for them depending on the formulary and co-payment structure for their health.